Hi, I'm Sue Kitchen, full CNC at Sir Charles Gardner Osborne Park Care Group. I'm here today just to talk to you about restless leg syndrome and falls management. So we'll look at what RLS is and the effect on falls risk and the treatments, pharmacological and non-pharmacological. What else can we do and how can we partnership with patients and carers, and about there is an Australian Health Promotional Day, and then briefly just some take homes that we can incorporate within our practice. So the very first known medical description of RLS was by Sir Thomas Willis in 1672, and I'll just read that description. Wherefore to some, when being abed they betake themselves to sleep, presently in the arms and legs leapings and contractions on the tendons, and so great a restlessness ensues that the diseased are no more able to sleep than if they were in a place of the greatest torture. There are some videos available of people who suffer from RLS at night, and when you watch that, it really does look like they are in a place of torture. In 1945, Carl Axel Ekbom provided a detailed and comprehensive report of this condition, and he actually coined the term restless legs. So what is it? It's a neurological condition and movement disorder. You have an uncontrollable urge to move your legs, usually due to leg discomfort. The primary reasons is that it is up to 50% genetic, and the secondary is that it can be associated with iron deficiency, pregnancy, renal failure, and many other diseases. The pathophysiology is that it is centered on the dopaminergic dysfunction and reduced central nervous system iron genetic linkages, and these all cause alterations in neurotransmitters. So to explain a little bit more about the dopamine. So RLS is related to a problem with part of the brain called the basal ganglia. Now the basal ganglia uses a chemical or neurotransmitter called dopamine to help control muscle activity and movement. The dopamine acts as a messenger between the brain and the nervous system to help the brain regulate and coordinate movement. If nerve cells become damaged, the amount of dopamine in the brain is reduced, and this causes muscle spasms and involuntary movements. Dopamine levels naturally fall towards the end of the day, and this may explain why the symptoms of restless leg syndrome are often worse in the evening and during the night. There is something else which is not to be confused with RLS, and that's called periodic leg movements sleep. The PLMS consists of frequent rhythmic movements of the legs and feet during the sleep, and it's a term that's used to describe a series of complex and involuntary, repetitive and very stereotypical upward movements of the big toe and downward and fanning motions of the other toe, and accompanied by bending of the ankle, knees and thighs. Now this needs to be diagnosed in a sleep lab, and they have a very specific diagnostic tool for this. There is an association of restless leg syndrome with type 2 diabetes, and this study shows it was the first controlled study that confirmed a significant association. So how does RLS relate to falls? Well, you can be you're very tired, you're very fatigued, and this means that you don't look or you don't make safe decisions based on what is happening around you. You pace, you fidget, you're agitated. And because this is happening at night the environment is often very unsafe. It's dark, or it's much darker, and it's certainly not light, and you're half asleep, and so this does make it very unsafe. You have muscular spasms. You diet as well, so you may not eat properly, and various diseases like Parkinson's and iron deficiency, which relate to RLS and are contributing factors to RLS, all have a risk of falling. And then there's the various medications. So there was one gentleman that was presented in some literature, and this was a 56-year-old gentleman with a history of RLS that presented to an emergency department after a fall. Earlier that night, he'd been unable to sleep because of significant RLS symptoms. So to relieve those symptoms, he walked around the house and fell down a poorly lit staircase, landing 8 feet below onto a cement floor, sustaining a severe TBI. Now that's a severe example, but you could see how this can happen. The evidence about RLS and also with falls is known to be of low quality. There's more robust RCTs are required, and the studies do need larger numbers. And not many studies specifically look at falls and RLS. Falls is mentioned more as a byproduct, but sleep fatigue and the quality of life are very much the more popular topics when you look at the evidence that's printed with RLS. And we know sleep fatigue and quality of life is affected by falls. Medications that can cause RLS: antidepressants, antipsychotics, antihistamines, antiemetics, calcium channel blockers, alcohol withdrawal, benzo withdrawal, and opioid withdrawal. There are other conditions that can cause RLS: iron deficiency anemia, magnesium deficiency, pregnancy, diabetes, uremia, rheumatoid arthritis, peripheral neuropathy, Parkinson's disease, multiple sclerosis, and those undergoing dialysis. Other causes to be considered are diet, so sugar and processed food, caffeine, alcohol, and smoking. So RLS is a common but frequently undiagnosed and chronic sensomotor disorder. In Western countries, it's seen in up to 10% of the general population. However, remember that it is often undiagnosed, so that number could be much higher. An effective treatment is very difficult to achieve, and it can also be a common feature of celiac disease. So what are the sensations? The sensations can occur on just one side of the body. They most often affect both sides, but they can also alternate between sides. So we can have pulling. So this will be where your muscles and your tendons feel like they're pulling in opposite directions, or pulling your foot down or your foot up. There could be a feeling like an electric current going up through your foot and through your leg. Your leg might itch, it might ache, it might throb. And then there's the awful sensation of bugs crawling under your skin. So when do the symptoms occur? Well, linked to the reduction in dopamine, it typically happens in the evenings or nights and while sitting or lying down, but it can also happen at any time of the day. And if you have a patient with RLS, you need to know this information so that you can assist the patient and help to manage and keep them as comfortable as possible. If no reversible factor, then the RLS will continue and it will get worse with age. You can have remission periods, but this is rare and they are often brief. So a little bit more at the detrimental effects of RLS. Well, you lose your sleep, and this means sleep and fatigue can infect every part of your life. It will infect your daily functioning because you're tired, you won't be thinking straight, you won't be, you're at risk when you're driving, when you're working, operating machinery. It can affect your family and your carers. So often you may find that partners will sleep in separate rooms so that the partner with RLS will be able just to walk around the room without fear of waking up their partner. It can make somebody very, very depressed and really worn out. It can contribute to falls, it can decrease your quality of life, it can increase symptoms of cognitive impairment, and as I said earlier, it really can affect your work or school performance. In this recording, I'm not going to show you these videos because I don't have the copyright. However, I do recommend that you go to this study and look at particularly video 2 and video 4. They provide a distressing but needs to be seen view of restless legs and how it can affect people. This study showed that there is definitely an association between restless leg syndrome and falls, but it also stated that the timed up and go or the tug should be part of any falls assessment, and that actually has recently been said by the World Guidelines as well. So how do we diagnose? There's no lab tests for diagnosis, and this very simple criteria is used as to how severe the RLS is. And diagnosis is very difficult for those with cognitive impairment, and this particular behavioural indicator test is one of the ones that seems to have been validated and is worthwhile using. It looks quite simple, and it is in many ways, but you need to go to this article so that you can learn how to use this particular test for restless leg syndrome in people with cognitive impairment. Management depends on the severity and the ranges of non-pharmacological to pharmacological measures, and there is an algorithm available. So this is for management of daily and intermittent RLS, and it's a very, very simple flow chart that provides you with medication and non-medication, non-pharmacological management. This was updated a little bit, but again, it gives you the pharmacological management was updated, and this is what it recommends for the intermittent and for the daily RLS. So these medications are the ones that the algorithm recommends, and all of them without fail are what we call false risk increasing drugs, FRIDs. So we have the dopamine agonists, and they're listed there. We have the dopamine precursors, levodopa, and other medication, tramadol, opioids, benzos, iron supplements, vitamin D and magnesium. I do recommend that you read this particular article there, because that was a wonderful article that detailed and outlined why these medications are essential, but also the side effects and what we need to be looking for. This is from that article, and as you can see, it tells you what the initial dose is, the usual daily range, but then your adverse effects. And again, these are all false risk medications, but you have to weigh up risk with risk. And to suffer with RLS is you will try anything to try and prevent or to reduce the RLS. So it's important that we try these medications and manage the falls risk as much as possible. Looking at Cochrane reviews, they looked at iron for the treatment of RLS, and iron therapy probably improves restlessness in comparison to a placebo. Levodopa for restlessness. This is effective for the short-term management of RLS. Opioids. The use of opioids for the treatment of RLS in patients that are resistant to conventional treatment is supported by very low quality evidence. So you can't really say whether that's going to work or not. And as always with these things, it is could be an individual patient will react much better than another. And benzos. There's no good data to support or refute the use of benzos, so again we're back down to individual patient effect. Augmentation is where there is an increase in the severity of symptoms with regular long-term therapy, and essentially that means that regular long-term therapy is no longer working, and it becomes that there is a risk that the doses, say for levodopa, will continue to increase and increase and increase, trying to get these symptoms back under control, when actually it might just not be worth it. It would be better to stop the treatment and look at something else. Looking at non-pharmacological management. So being able to talk about RLS does increase the feeling of being understood and empowered, and patients want much more information, and they have a fear of how to cope when in hospital. And when you read the forums that are online, this is really massive. There is a genuine fear for people that they won't be able to be allowed to cope with their RLS how they know that they need to cope with it. So again, when we're looking at our patients, we need to be taking this into consideration. We need to listen. We need to ask for interventions that work. The patient knows best. Provide some information if they would like it, and look at providing any other referrals they may not have had or that they may need. There are lifestyle modifications, so we can reduce and abstain from caffeine, chocolate, soft drinks, nicotine and alcohol. When they're in hospital, we could put them on a caffeine-free diet. Sleep routine is essential, and we need to know that. So if the patient normally goes to bed at 9 o'clock at night, then can we facilitate that? A routine, as far as possible, is important in modifying RLS. There is evidence for capsicum gel, but this must be prescribed or run past the medical officers first before that is actually used in hospital. Regular exercise, yoga has found to be very effective. Yoga prior to bed is found to be very effective. And if you look online for yoga for restless legs, you'll find plenty of YouTube videos and printouts to be able to use. And gentle leg and foot massage, and that is something where we can bring in the family. So before the family go home in the evening, we can teach them or ask them just to give gentle leg and foot massage to the patient, just to try and help relieve that RLS. With the diet, look at iron replacement. The banana seems to have some evidence behind it. It's a little bit, but we do need to check with the medical officer because obviously it contains potassium. Avoid sugar and fatty foods and chocolate, avoid caffeine, and consider a gluten-free diet. There is this study here which found that after 6 months of a gluten-free diet, the RLS symptoms improved in 50% of the 28 patients that were involved. So, it can be looked at and considered, but certainly needs medical assessment before going down that line. There's a vibration mat, which I'll talk about in a moment. There are TED stockings as well. Hot or cold compresses to the legs can help. For people at home, taking a hot bath to relax the leg muscles. Hot or cold foot soak. Aromatherapy, I'll talk about in a moment. A weighted blanket and near infrared spectroscopy. So these light beams with long wavelengths, they're used to penetrate the skin and they cause the blood vessels to dilate and increase circulation. This is the Relaxis pad. I put this up here just for information. I do not recommend any type of equipment, but it is interesting to note that the forums indicate that having a vibrating pad is very effective for some people with RLS. It helps to relieve the symptoms. This particular pad provides timed vibrations that is designed to counter the body's own stimulation. There are no independent studies that have confirmed any type of success, but I'm just going from internet forums where some people have indicated that having a vibrating pad from whichever company works. There is also a restless leg foot wrap, huge falls risk, but it's an adjustable foot wrap that applies pressure to 2 muscles in the foot and can offer patients with RLS an effective alternative to drugs to ease symptoms when trying to rest or go to bed. So in a pilot study, researchers found that the device was 1.4 times as effective as a standard drug treatment. Again, I do not recommend these types of equipment, but there is some minor evidence that these may work, and we have to consider these things because they will work with some people and not with others. Reflexology. This study looked at the effects of 2 methods of reflexology and stretching exercises on the severity of restless leg syndrome among hemodialysis patients. And they found that these 2 methods of treatment are effective. They do reduce the severity of restless leg syndrome and can be recommended. So I do suggest that you go to this particular study and have a look if you are caring for patients on hemodialysis. And then there was the effects of foot massage on hemodialysis, sleep quality, and restless leg syndrome, and a comparison of lavender and sweet orange essential oil topical application. It was a double-blind randomized controlled trial on 105 hemodialysis patients at a large educational hospital in Iran. What was found was that aromatherapy prepared with lavender oil and sweet orange may be recommended to increase sleep quality and RLS level of the hemodialysis patients. So again, I recommend going and having a look at that study to see whether it might be able to help your patients. There is a lot of articles out there and research being done on dialysis and RLS, and much of this is very relevant to bedside practice. So again, recommend go out, do a lit search and have a see what's there. So if we're going at inpatient care, we need to make sure we have a medication review, because so many of the medications can contribute to RLS. Can we look at that deprescribing type of structure? A sleep or behavioural diary to include leg movements, particularly if somebody has CI, would be useful for all of us, and useful to be able to plot when we need to mobilise the patient, when they're trying to move and the reasons why they're trying to move. Having a documented diary will help. Regular exercise during the day, so getting the patient up and about during the day. Bedside exercises, which the physio can provide, and we need to encourage the patient to do. And of course, we can bring the family in with this one. TED stockings, and in severe cases, you could consider flotrons at night. Keep the patient to a regular sleep routine. Reduce the periods of sitting or lying down because they might trigger symptoms of RLS. Maybe consider having hot milk and a banana for supper. Refer to a sleep clinic if they're really not sleeping. If it's really bad, the sleep clinic will be able to review the severity of RLS. Get the dietitian to come and review the patient's diet and what modifications could be made. Could we trial a vibration mat? Is that something, if you're in an area that has a lot of patients with RLS, perhaps that's a research or quality improvement activity that could be considered. Include the timed up and go in all mobility assessments, and be aware of possible augmentation. The partnership with the patient and with their caregivers and their family. Give them some education about RLS and teach some gentle massage to the calves and to the feet. Feet into warm water in the evenings, only when the family is there, so they can be supervised. And bedside exercises could be encouraged. And the family can assist with all of this. So rather than coming in and just not sure what to do or what to say with the patient, this hands-on care might actually be very satisfying and encourage family to come in more often. I don't know, but certainly working in partnership with the family and the patient in RLS is going to be effective. So, old wives' tales, or are they? Because we know old wives' tales have come from somewhere. So, corks put near your feet in bed. These have always been known to considered to reduce cramps. There is no evidence for this. Drinking tonic water, a tiny little bit of evidence, and that's really just from forums. It's not scientific evidence at all. Few potatoes in bed, no evidence for this one either. Eating yellow mustard before bedtime. In the forums, you'll find that there are many people who swear by eating yellow mustard before bedtime that it really does help their RLS, but I couldn't find any scientific reason or scientific research on that. Having a gin before bed, I think that's probably got a lot to do with the tonic that goes in it. And the soap under the bottom sheet or in a sock. Now the soap, there might actually be some evidence for this. Apparently soap gives off molecules, and these molecules might actually help RLS. There's a tiny little bit of evidence around that, which certainly needs much more research. So is RLS underdiagnosed? I think we can safely say that it is. And getting back to the fear that people have of being in a care situation where they're not able to speak for themselves or unable to walk, but they're still suffering with RLS, it is very great. So we really should be including it in our questions, our admission questions, our assessment questions. It should be there. We need to know about it so that we can actually help the patient, and so they do not have this fear when they're in hospital. There is a Restless Legs Awareness Day. It's an international day on September the 23rd, which is something you might like to consider promoting this year. More information and more resources, please see all of these different foundations and organisations. So just some practice tips to consider. Augmentation can occur, so the patient means that the therapy is maxed out, but their RLS symptoms are getting worse. Medication needs to be reviewed. Take the history from the carer if the patient is unable to provide it, and involve the carers. Make it a partnership. Leg exercises that can be completed not only during the day but during the night. An exercise regime for daytime. A sleep chart that includes behaviour that specifically is looking at the legs and the restlessness. And a dietitian review. Thank you very much. If you want a copy of this presentation, please do not hesitate to email me. Thank you.